So then, Sucheta, please.
लेफ्ट की शुरू कहाँ से कर रहे हो? इधर
इधर से
डॉक्टर सुचेता
लेफ्ट.
नहीं सर वो शायद
नहीं वो बता देंगे ना. इनका लोड. हाँ, ठीक. She'll be speaking on current concepts in management of esotropia. You have 8 minutes.
Very good morning to all of you, and I should thank the AIOS and Dr. Dadia for giving me this opportunity. Basically, I'll be talking on the current concepts in diagnosis and management of acute acquired esotropia. I have no financial interest in this presentation. What is acute acquired concomitant esotropia? It is characterized by sudden onset of strabismus accompanied by diplopia with no significant changes in the deviation of angle in different gaze positions. So it is basically classified as acquired committant and incompetent esotropia. And the classical teaching, which was that the acute acquired committant esotropia was 3 types. Type 1 was the Swan type, type 2 was the Buren-Franceschi type, and type 3 was the Belchowski type. But slowly what was added into it was the acute accommodative, decompensated phoria, neurological type, cyclical, and what we are more concerned and which we have seen more in the after COVID period was this excessive near work esotropia. This was another classification which was underdone by Go et al., which showed that excessive near work activities as well as the neurological diseases and extraocular muscle tone was also giving rise to this acute esotropias, and there was other classification also which was made depending on the amount of deviation, whether large angle or small angle deviation. So what exactly is this acute acquired concomitant esotropia? The onset is more than 6 months of age, because we know which is less than 6 months, it's more like an infantile esotropia. There is no lateral incompetence and it has an acute presentation. What it does not include, which is very important also to rule out, is, or which will be stimulating it, are the acquired 6-nerve palsy, idiopathic intracranial hypertension, and ocular myasthenia gravis. Looking at the incident, this is around 4.9% of all childhood esotropia in a hospital-based setting, and it varies from 14 to 16. So it's actually a rare disease. So we'll come to different cases. This was a 2-year-old child who had been advised somewhere else for a prolonged patching. And we saw that the parents were patching full-time. They had kept the child with the patching for 2 days. So the child was presenting to us 3 weeks after, and this is what is the inward deviation we could see, and this is typically the type 1 or the Swan type. So what exactly occurs over here? There is a monocular occlusion, so there is an artificial disruption of fusion. So when we ask the question, are all children who are patched will be having this type of esotropia? Not all, but all cases, those who have a latent convergent tendency and they have a slim fusional reserve with a loss of this simultaneous binocular perception are likely to undergo this type of acute esotropia. Coming to the second case, this is a 6-year-old female who presents with sudden onset inward deviation of the right eye, and there was a history of a viral infection 1 week back, and you can see the right ET with a 35 prism diopter, and ocular motility was full and free. So this is the typical idiopathic or the Franceschi type, which has a minimal refractive error, no accommodative component, and is usually precipitated by viral infection or a minor head trauma or psychological stress. It's because of this poor fusional divergence, but binocularity is maintained in these cases. Coming to the third type, this was the 7-year-old female giving a history of voracious reader. She was not using any spectacles, and she had a low vision in both of her eye. Refraction, cycloplegic refraction showed -5 diopter and -6 diopter in both the eye, and PBCT around 45 prisms ET. And this is the typical Belchowski type, which is because of the uncorrected myopia, and it is because of prolonged near work. There will be a small ESO for distance, but they are ortho for near. But slowly as they go on reading more, there is a persistent convergence, increased tone of the medial rectus, and decreased fusional divergence, leading to a constant esotropia. So coming to another case, this is a 8-year-old male who come towards with sudden onset of deviation. Cycloplegic refraction is +6 and +8. PBCT was 35 prisms ET, prescribed glasses, and then also after 3 months when we saw it is same 30 prisms ET. So the question comes, are we dealing with an acute accommodative type or a refractive accommodative type? Then how do we differentiate? Well, there will be a onset which is a sudden, and in accommodative there will be a large angle deviation, constant deviation, diplopia will be there, and binocularity is usually preserved. And in refractive type, more often it's asthenopic symptoms and amblyopia and poor binocularity will be there. Coming to this case, this is a 12-year-old female with an inward deviation of the eye, history of using mobile phones and iPads. Visual acuity is almost 6/6, cycloplegic refraction is not much, and this is what we are dealing with, this new generation's smartphone type of esotropia. So short working distance, they have a postural thing, they go nearer and nearer, they go on seeing, and there is a intense activity and addiction to this mobiles, and they have this type of a esotropia. What we should not forget after doing a cycloplegic refraction and history taking and is the fundus examination, because some of these cases can have a papilledema. So acute sudden onset with a nystagmus if you find, and if you have a papilledema, you are dealing with a case which is more of a neurological type. So the question comes, should all of these cases should have a neuroimaging? Well, we know tumors of cerebellum and Arnold-Chiari malformation is more common in some of these children. Literature says it is around 6 to 30% significant finding on MRI, and Setter all had done the maximum, have the highest study which they are showing that 16% positive findings on MRI and 13% required a further evaluation along with even though the neurological examination was normal. So since there is a lack of consistent predictive factors, it is better to neuroimage. What are the red flag signs of neurological etiology? Older age group, neurological symptoms and signs if they are present. If they have a poor fusion, there are associated nystagmus, and there is a recurrence of esotropia. Well, these are the cases which should have a neuroimaging. What is the management protocol? You give the glass prescription, do a amblyopia therapy, but more of a orthoptic exercises. You can go off about giving them the prism glasses. Fusional divergence exercises may not help much, but it can be done in the form of vision therapy or Brook string. Botox in the initial stages you can give. First injection 50% resolution, but you may require 2 to 3 injections. And then we go about for muscle surgeries, but that only after 8 months, or you have fully seen the patients after doing a prism adaptation test, and you only operate for the largest angle. Well, the surgery is either you opt for a bimedial recession, you do a unilateral MR recession, LR recession, or 3 muscles with adjustable. The important thing which comes is whether we'll do a standard dose or a augmented surgical dose in these cases. And the better prognosis is if you have a good fusion or there is a hypermetropic type. So my take-home message is acute onset concomitant esotropia is an unconfirmed form, and SPART form uses should not be neglected, and abducting nystagmus and lack of binocularity may be sign of an underlying neurological disease. So neuroimaging has to be advised as per the need, and if the esotropia is not resolving. Thank you.